Um, Good evening to everyone present here. I would be presenting a clinical case series at a secondary care hospital on Cousin Germain of the Great Bubonic Plague 1665. Cousin is a French title saying first cousin, and Germain refers is another French term for saying it's from the same origin. So this is another name for spotted fever, which was termed in 17th century when it was first said. So there is an increased prevalence of rickettsial diseases along the Eastern Ghats and the Siliguri Hills, of which spotted fever is the most common reported, is the most underreported, and scrub typhus as the most reported. The causes for this includes that the spotted fever is the most common tropical mimicker and has a varied presentation. There's a mortality of around 40% for more than day 6 of presentation, hence saying that this disease needs to be identified and treated earlier with doxycycline as soon as it presents. This was the main reason and as to why did we undertake the study, and the objectives were to understand the clinical profile of these patients over the past 5 years, along with the attempt to assess the severity as well as outcomes in each of these patients. A total of 8 patients were spotted fever IgM ELISA positive. Most of them presented in the months of September, January, and October, which corresponds to the winter rainfall of this in our area. They presented with fever more than day 6, with high grade and chills, and along with their end organ damage, most common organ being skin, and presenting as a maculopapular and a purpuric rash, having a palmoplantar involvement, usually starting on day 1 or day 3 of fever onset. The other end organs included presenting with altered sensorium or stroke involving CNS meningoencephalitis, ARDS presenting with breathlessness, AKI or creatinine having with elevated creatinine levels, as well as decreased urine output. Because high spotted fever, like rickettsial diseases, was common in our area, we started them all on doxycycline on day 1 of presentation itself, along with other antibacterials, and other tropical diseases were evaluated slowly, including malaria, dengue, scrub typhus, Vidal for salmonella, all of which were negative, and slowly the antibiotics were de-escalated. A total average duration of 10.625 days of doxycycline was given for all patients, and a total hospital duration of 6.125, with all of them being alive, and good full mortality benefit was present. Regarding the mean of hemoglobin platelet and sodium levels was done over day 1, day 2 to 5, and day more than 5 of antibiotics, which had showed an improving trend, whereas transient drop of hemoglobin, which was self-recovering, which is a very new observational finding. However, further studies are needed for verification. Q-SOFA attempt was done to assess the severity, which had shown a decrease in hospital stay and decreased ICU admission, but it was statistically not significant because of the low sample size present. The main learning point which we take away from this main poster is that whichever patient is coming with fever, as well as maculopapular rash, we're having a palmoplantar involvement and end organ injury, needs to be warranted with started with doxycycline initiated. And whereas which is because in pregnant female as present in one of our cases, we cannot use doxycycline. So azithromycin is used and in other cases. This helps in mortality benefit as evidenced in our study. Thank you.
And this way here, you have said that any patient coming to the hospital with a rash, you should start on doxycycline. Is that what you said? Conclusion.
No, sir, a small correction to that. I meant that patient who's presenting with fever, with rash, along with an evidence end organ damage, should have a high suspicion for spotted fever, and they should be started immediately with doxycycline.
And that's the way I would think. See, if you look at the epidemiology of, well, let's say, for example, perhaps the most common disease which is coming with short duration is dengue. So you must have some kind of an understanding after what duration presenting after 3-4 days. Then maybe what you're saying is right. Because if you want to stay present, somebody comes on the day 1 with a rash, to say that you must start, because that's probably more direct dengue than with rickettsial. Okay, so for that to understand, you must have a data which suggests after how many days was the presentation. And if you say all of them are 5-6 days presentation, then it makes very good sense.
Yes, sir.
That is the recommendation, by the way, of public health now. Anybody with fever of non-specific localization, after 5th day, you must start on the drops.
So, Priyanjali, you had 8 patients.
Yes, sir, who was spotted fever IgM ELISA.
Doesn't matter. 8 patients over a period of September, October, 6 seasons.
Yes.
Okay, no problem. And these 8 patients all survived. Very good. The next point I'm trying to say is you found sodium level is little low, and you found hemoglobin is little low. How do you explain it? We can explain it by water expansion. So when we say water expansion, it means that they are either coming, drinking a lot of water, or you've given a lot of fluid. Otherwise, you cannot explain that, which has improved. And you would have given more water, 5% dextrose or sodium chloride. So how are you explaining that phenomenon?
Sir, so rickettsial diseases are known to present with low platelet counts as well as low sodium levels as well. So the first day one, which was the values which we found as the mean average, it was actually before any it was like as soon as the patient presented, before any intervention could have been done. And then progressively the sodium levels as well as the platelet counts were progressively monitored.
I'm challenging you in your lab values, parameters, etc. Because when we teach dengue, we say that the PCV is high. You're saying in scrub typhus or so-called scrub typhus fever, the hemoglobin has dropped by 2 grams. 9.1 has come up to 11.1 average. And sodium is 130, which is mild hyponatremia, which has improved to 134 with whatever you did or with the resolution of fever, plus platelet count, which is low. So something is happening, fever with platelet count. So what is your final inference? What are you telling me? Start on doxycycline for day 1 fever with such findings? It's okay if patient is sick. Your Q-SOFA, liquid SOFA, the score was low. So therefore, sorry, high. Okay.
Yes, more than 2.
More than this thing. So you may have started. You are permitted. World is permitted not to take any chances when somebody's quick SOFA score is high. So therefore, you have started on an antibiotic with the pretest probability that it may be scrub typhus. That is all you can say. But will you scale up? You have to do a blood culture also, okay, in such patients.
So I'm sorry, I couldn't mention the blood cultures were negative for all of these patients.
For all of the...
Yes, sir. Blood culture, Vidal test, malaria, dengue, and scrub typhus. All 5 of them were negative.
Negative. So
Yes.
maybe some other thing. Responding to doxy or maybe just responding to something. Okay, maybe your presence. Thank you. Thank you.
Thank you.